Thank you so much. It is an absolute pleasure to be here today, along with my colleague, Cat Cox. We're both doctors and ethicists working together on this question of how do you communicate or not communicate diagnostic uncertainty. As Liz said, we're going to make it a little bit interactive. So if you could join on slido.com and put that number in 305-2899. I understand it's also in the chat. So when I move on from this slide, you'll have more opportunities to see that number in the chat, and then it's also in any slides we do that are interactive. So before we talk about diagnostic uncertainty, we need to make sure that we understand the diagnostic process. And I understand that the people at this space today are varied: doctors, patients, healthcare professionals, all kinds of people. So I just felt it was important to make sure that we understand a little bit about the standard diagnostic process. And this is not a static process, it's very dynamic. So a patient presents with symptoms, something is bothering them, something is wrong. And as soon as they start telling the symptoms to the doctor is forming a differential diagnosis. That is a list of possible causes of why this patient has these symptoms. And they'll examine the patient, and maybe they'll find something they weren't expecting. Maybe they'll find the patient has a big liver. So they'll add extra things to their differential diagnosis list, and they'll cross some things off when they find, oh, patient doesn't have any signs of breathlessness or whatever else. So that the list is dynamic through the taking of the history and the examination. On the list that they have, they'll have something that is the most likely diagnosis that they'll be holding in their head, their kind of working diagnosis, but they'll also potentially have something which is the most dangerous thing, the thing that needs to be ruled out. And sometimes those dangerous things you need to start treatment on even when you're not sure. So a classic example is a patient coming in with a headache and a temperature. You're going to be worried about meningitis. You're going to start them on antibiotics, even if you think that's not the most likely thing. So you're going to give them a treatment. And sometimes we do trials of treatment in order to see whether that diagnosis is likely. And at the same time, we'll be doing investigations, blood tests, radiology, all kinds of things to try and hone down what the diagnosis is. And if we're lucky, and I say if we're lucky because it's not in most cases, we'll come up with a definitive diagnosis. We'll be able to say this bacteria was causing this infection in this organ, or this was the cancer, and we know because we saw it under the microscope, and we'll be able to give someone a definitive diagnosis. But quite a lot of the time, we stick with our working diagnosis, what we think is the most likely statistically with the information we have. And quite a lot of the time, we actually give a diagnosis of exclusion. So we say, it's not this, it's not this, it's not this, it's probably musculoskeletal pain. So we could end up with different places, and patients often do. So I'm going to hand over to Kat now to talk a bit about when we encounter diagnostic uncertainty and talk through a worked example of this.
Yeah, so the main thing to think about is that, as Zoe has alluded to, diagnostic uncertainty is actually really common in medicine. And we see it in lots of different specialties, particularly in areas such as in emergency medicine or in primary care, which see lots of undifferentiated presentations. But actually, we see diagnostic uncertainty across lots of different medical specialties. And a key role of the doctor is learning to make decisions in, decisions in light of diagnostic uncertainty, particularly thinking about whether further investigations might be needed. So I'm just going to talk through a case example now, which is an example of a very common clinical situation, which we see as doctors all the time, which involves quite a high degree of diagnostic uncertainty. So let's say a patient comes to A&E with some chest pain. There are lots and lots of different things that can cause chest pain. So at the initial presentation, the differential diagnosis, that list of things that could be going on, will be really broad. We might be thinking about things such as a heart attack, a blood clot in the lung, even musculoskeletal pain or acid reflux. The doctor will listen to the patient's story and will examine the patient, and will come up with a working diagnosis. That diagnosis we think is perhaps the most likely. Let's say in this case, the working diagnosis is a heart attack, also known as a myocardial infarction. We'll then organise further tests, in particular things like blood tests and a heart tracing, which we hope will help confirm the diagnosis. However, it's actually very common for the investigations not to confirm a diagnosis, but just serve to exclude other diagnoses. So let's say in this example, the blood test and the heart tracing are both completely normal. That essentially rules out something like a heart attack. And we're left to sort of reassess and think about what other diagnoses might be going on. Something we might think about is something called angina, which is where the heart muscle is not getting quite enough oxygen for a short period, causing some pain, but typically not causing any changes to the heart tracing or blood test. Because there's no sort of definitive investigation at this point, we'll say it's definitely angina. Often it can be quite a clinical judgment if we think that's what's going on. We might think about other diagnoses similarly that wouldn't cause any change to the blood test or the heart tracing, such as something like acid reflux. At this point, it would be quite common for a patient to be discharged from A&E without a definite diagnosis. They may well be given a label of something such as angina, which is far from 100% certain. The key question we're interested in is whether doctors, how should doctors talk about this uncertainty in diagnosis with patients at various points in the diagnostic process? Something else we just want to clarify is the difference between diagnostic uncertainty and medically unexplained symptoms, which I think sometimes people think we're talking about the same thing. Medically unexplained symptoms describes a situation where a patient has persistent symptoms for which medical professionals can't find a sort of physical cause. Now, clearly, in situations of medically unexplained symptoms, there may well be a lot of diagnostic uncertainty. But the main thing we want to get across is that diagnostic uncertainty occurs in lots of different areas of medicine, not just in situations of medically unexplained symptoms. It's actually very uncommon for us to be 100% certain about what the diagnosis is. So we've done a lot of talking now, and we'd really like to get you involved. So I've given one example, the chest pain example, of where diagnostic uncertainty is common. But we'd really love if you could share some examples of where you, or perhaps someone you know, have experienced a lot of diagnostic uncertainty. So join us on Slido now, and just to reassure people, your name, this is all anonymous, so if you type something in, your name won't come up on the screen and we won't be reading anyone's names out. But we'd love if some people could join and give us examples of where you or someone you know has experienced this.
Just to add, if you keep your examples reasonably short, because we're slightly concerned if they're very long, you'll be typing them and then we'll have moved on to the next question. So just examples. The idea of this was to get you guys thinking about the kind of things you might have thought, well, actually, no one really told me what the answer was there. Or yes, this is something that's common. And then we can try and bring in our empirical data, which we're going to present in a moment. Exactly. A viral versus a bacterial infection, super common. So patients going to a GP with a temperature and a sore throat, and a GP saying, I think it's probably a virus, but they don't know. Sometimes they could give a just-in-case meds. Headache. So what on earth is the headache? Is it a migraine? Could it be a brain tumor? What are all the problems? A collapse and loss of consciousness is an outstanding example of where there's diagnostic uncertainty. We don't know if it's coming from the heart. We don't know if it's coming from the brain. Often we do a whole series of tests and we can exclude some things, but we're not entirely sure because we weren't there at that moment. Pelvic pain, what's causing it? All these different kinds of things. So I obviously can't go through all of these, but bowel symptoms, inflammatory bowel disease versus irritable bowel syndrome, extremely difficult to get down to the bottom of. Okay, so what you have demonstrated to us, this is fantastic, is that there are many, many, many and commonly presented examples of diagnostic uncertainty. So I want you now to turn to what reasons you might be able to think of for why a doctor might not tell a patient that there is uncertainty in their diagnosis. So what kind of things might prevent a doctor from doing that? And again, try and keep them pithy. So short answers so that we can get through them. But what might motivate a doctor not to? That might be one from the last one. But yes, uncertainty about I can't even think of what the differential might necessarily be for pain or anything like this. So lack of time. Yes, we're all working in incredibly pressurized environments at the moment, and it might just be easier to try and cut to the chase to see, this is what I think it is, off you go. They're worried about the patient reaction. Yeah, so they might be worried that the patient is going to lose trust in them, that the patient might lose confidence in their clinical ability. Absolutely not wanting to scare patient anxiety. You can see this coming up a lot, make them worried. That's really common, unnecessary anxiety. So why would you might not tell a patient because maybe there is a possible dangerous diagnosis, but if you tell them that, it might make them really worried. They're not certain about their own uncertainty. Yep, absolutely. This idea of not having confidence, protecting themselves. So perhaps preventing them from having litigation or other things. And again, lots of these, so repeated questions about time constraints, confidence, and anxiety. Okay, so now if I just get you to think on the opposite side, can you tell me some reasons for why you think a doctor what might motivate a patient to tell them that there is uncertainty in their diagnosis? Yes, absolutely. The doctor is saying, well, I might have missed something, and I don't want to leave that patient sure that there isn't something dangerous. So I need to share that information with them so they can take part in that as well. using the time to help with the diagnosis. So they might tell a patient and say, we need you to be on board in order to make sure doing tests happen. And interestingly, this person has written mitigate anxiety. So we had not causing anxiety for not telling a patient, and now we're having not causing anxiety by telling a patient. Safety netting, absolutely. So you're saying, let's look out for future symptoms. Let's make sure that we've explained. Honesty, absolutely. You can just say, this is being honest with a patient, transparency and building trust, being honest. So all of these things are absolute reasons why doctors might do it. So we thought this was quite a big topic as we looked at this, and we wanted to know what was already known before we kind of launched in with our own ideas, what is already known about the communication of diagnostic uncertainty and the ethical issues associated with it. So Kat and I, along with colleagues, did 2 systematic reviews of what is known both in primary care and secondary care about diagnostic uncertainty. And in summary, we found that really there's not that much known. We know that it exists everywhere. We know that people find it very challenging. We know that doctors aren't really trained in it. And we discovered from this that there's very little patient focused research on it. So there were a lot of questions left. What are the ethical considerations in both communicating and not communicating diagnostic uncertainty? We'll come and investigate that in a second. What are the professional or legal constraints on there in terms of the communication of diagnostic uncertainty? What do doctors do currently? So you guys have just given us lots of reasons both for and not for communicating diagnostic uncertainty, but what do people actually do? How do patients feel about that? If a patient gets told about their diagnostic uncertainty, do they actually feel anxious, or is that just something that we're projecting on them? And what are the consequences of communicating or not communicating diagnostic uncertainty? So obviously this was a big program of research, and we used an overall applied clinical ethics research approach to try and address it. And this explains the whole program of work. So we had a multidisciplinary team working on this, including ethicists, lawyers, and anthropologists, and we did a series of studies. And obviously we don't have time to talk through the whole 3-year project in this period. We're going to focus on the doctor vignette study, the public vignette study, and the ethnography. And I am going to very briefly introduce you to the ethical and legal analysis. So we started with the ethical analysis. And this was a question of, is there a right amount of information to share? Is there a way, as a normative question, how much diagnostic uncertainty should we be sharing with people? And if you look at the current landscape in terms of professionalism, in terms of ethics, absolute primacy is given to autonomy. In fact, I heard Liz say earlier, no information about me without me, or words to that effect earlier on one of them. So surely if we follow that, we should be telling patients absolutely everything. There should be no question that we should be hiding any of the kind of process of our diagnosis to them. But there are some issues with doing this. So I worked with one of my colleagues, Richard Holton, who's a professor of philosophy at Cambridge, and 2 big issues came up, and they were essentially based around trust and responsibility. So if you give patients more information about every possibility, it risks, and there is evidence that it is associated with, inappropriate over-investigation, because you are substituting information for trust. So instead of the patient giving the doctor some discretionary trust about what needs to be ordered or what needs to be done, you're handing over this uncertainty, and people start searching for certainty and they seek over-investigation. And that has problems on a justice point of view in terms of resource allocation, and it actually has problems because some investigations are invasive and harmful. We asked the question, can taking responsibility for uncertainty be a moral good? Is that actually part of what a doctor does? Does a doctor, in looking after a patient, say, you can stop worrying? One of my colleagues said, let me do the worrying for you, to a patient, which could sound really condescending, but you can also imagine for other patients, them going, oh, okay, I'm going to stop worrying about this and hand over to you. Is that part of what a doctor's job is? We came across this interesting idea that more information doesn't always enhance autonomy. So if you assume that giving extra information leads to greater autonomy, that needs to be challenged a bit. In order for that to be true, the information has to be very understandable to the person who's getting it, and they need to be in a fit state to process it. And often we're making these decisions in A&E departments with patients we've never met in highly stressed situations. So more information doesn't always enhance autonomy, and arguably autonomy doesn't always enhance well-being. It often does, and certainly having agency to be able to have control over certain elements of your health does, but it doesn't always enhance well-being, and understanding in what circumstances it does is critical. It's not enough to just say it depends on the patient, because as we'll see later in the talk, that might introduce all kinds of bias and inequities. So what does the law say, and how should we interpret it? I did this work with colleagues in Cambridge. We looked at case law, and we also did interview analysis of lawyers. And it's quite complex. So this is a very summary slide. But essentially, there was a judgment in 2015 called Montgomery, and which I'm sure many of you are familiar with, which was about talking about treatments and reasonable alternatives to treatments. And the judgment was that the doctor is under a duty to take responsible care to ensure that the patient is aware of any material risks involved, of any recommended treatment, and importantly, of any reasonable alternative or variant treatments. So that's in the law about treatment options. And what we wondered was, could this also extend to the disclosure of diagnostic uncertainty, seeing as if there are different diagnoses, that's very closely tied to different treatments. So does this Montgomery judgment extend to the disclosure of diagnostic uncertainty? And we concluded that it did. So that was the principal ethics and law before we started, and then we went on to do empirical studies. And I'm going to hand back to Kat to explain questions of what do doctors do and what do patients think about it. Kat.
Yeah, so I'm now going to talk through two different vignette studies that we did. First one looking at doctors, and the first one more focused on patients. So CODIS stands for Communication of Diagnostic Uncertainty Study. So we did two studies, CODIS 1 and CODIS 2. CODIS 1, what I'm going to talk about now, was very doctor focused. So we were really interested in trying to work out what doctors currently communicate in terms of diagnostic uncertainty, whether there's any variation in what doctors currently do, and then trying to understand the reasons for any variation we saw. Participants in this study were all doctors working in general internal medical specialties from a range of different grades, so from first-year qualified doctors right up to consultants. We developed 4 different written vignettes, all depicting common clinical situations which involved a degree of diagnostic uncertainty. Participants were given each of the vignettes to read on screen. After they'd read the vignette, we then asked them to tell the online interviewer what they would tell a typical patient in this situation. So we were essentially asking them to imagine that the interviewer was a patient and getting them to communicate as they normally would. After they'd responded to all 4 of the vignettes, we then did a short semi-structured interview where we tried to explore some of the reasons for why they had communicated as they had. And we also tried to understand what training, if any, they had had in this area. I think the next slide really just sort of shows that information in a visual format. But just to reiterate, people responded to 4 vignettes in a randomized order. After they'd responded to all 4, that's when we did the interview again. The text in red there are the clinical vignettes we chose to do. And we developed the vignettes through a combination of expert input and pilot testing. So we had one that involved a change in bowel habit, one that involved an elderly patient with anemia and back pain, one that involved chest pain with essentially normal investigations, and finally one that involved a headache with a normal CT scan. So I'm not going to talk through all vignettes, 4 of them in detail, but just to go into one, just to give you a bit of a better sense of exactly what we did. So the text on the left there in italics is essentially what participants actually read on screen. The text on the right is a bit of a translation, because I'm aware not everyone watching this is going to be medically trained. So just to very briefly explain, when a patient comes in with a very sudden, severe headache, one of the important diagnoses we don't want to miss, and we think about it a lot, is something called a subarachnoid hemorrhage, which is a type of bleed on the brain. Now, a CT scan is pretty good at picking up a subarachnoid hemorrhage, but importantly, it's not 100% sensitive. So in a small number of people, it's possible that you could have a normal CT scan, but still have a small bleed. Because of this, we sometimes go on to do a further test, which is something called a lumbar puncture, which involves putting a needle into the back to try and sort of more definitively rule in or rule out a bleed. Now, generally speaking, if we do the CT scan very soon after the headache comes on, it's actually probably good enough to try and rule out a bleed. And actually, if it's done within the first 6 hours of the headache, we often don't need to go on to do that extra test. So in this scenario, although we're not 100% certain that the patient hasn't had a bleed, the overall risk of having a bleed is so low that in this case, doing a lumbar puncture the risk would not be worth it. Clearly quite a lot of complicated uncertainty information there. And what we were really interested in was giving that exact same information.
I'm sorry, I'm on the slides and I apologize. Right, sorry, it was me. Go ahead.
We were really interested in giving lots of different doctors the exact same clinical information and seeing what they all chose to communicate with the sort of hypothetical patient. So in terms of what we found, there was an awful lot of variation in what doctors were currently doing. So even though everyone was responding to the exact same vignettes, all our participants chose to communicate quite different things. Importantly, many of our doctors did not explicitly acknowledge diagnostic uncertainty, even though they themselves were not 100% certain about the diagnosis they were offering. They took lots of things into account in deciding how to communicate, which I'll discuss in a bit more in a moment. But importantly, there was very little training in this area. So almost all of our doctors said they had not been trained in how to communicate uncertainty, either in medical school or in postgraduate training. So to focus in again on the headache scenario, just to give you a sense of what people said, the majority of our participants said that the CT scan was normal, and sort of often said this in a way that implied that this had definitely ruled out, which is, perhaps not quite the case. A very small number of people did introduce the idea of the CT scan having a certain sensitivity, but actually only one participant explicitly stated that the CT scan was not 100% sensitive. Similarly, although lots of participants offered some safety netting advice, so lots of people said, come back if your headache gets worse, only one directly linked this to the risk of diagnostic error. So only one person explicitly said, it's really important that you come back if your headache gets worse, because there is a risk we've missed a more serious diagnosis. Doctors gave us lots of interesting, quite varied reasons for why they had communicated as they had. Something we wanted to highlight, something we found really interesting, was that doctors often expressed quite conflicting and sort of opposing ideas about what the impact of communicating diagnostic uncertainty might be on the patient. So lots of people talked about this idea of wanting to reassure patients or reduce patient anxiety, but they often had quite different ideas about how to achieve this. So some people, as in that top quotation, felt that acknowledging uncertainty and expressing uncertainty in diagnosis would be worrying for patients, would not cause reassurance, and as such, they didn't do it. In contrast, we had some people who said they felt being very open and transparent and talking through the thought process, including acknowledgement of diagnostic uncertainty, would in fact be more reassuring to patients and would give them a better idea of what was going on and make them sort of perhaps trust the document. So here we had people who had similar goals of communication, i.e. they wanted to reduce patient anxiety, but they had different ideas about how to achieve those goals. And as such, we saw different communication behaviors. So why does all of this matter? Well, this study suggests there probably is quite a lot of variation in terms of what doctors are currently doing in their communication of diagnostic uncertainty. Some of this may well stem from the fact that doctors had quite different ideas about what the impact of communicating diagnostic uncertainty was on patients. Something we really want to highlight here is there is a huge lack of patient-focused research in this area. So we actually don't really know what the impact of communicating diagnostic uncertainty on patients is, and we certainly don't know what patient preferences are. So no one has really asked patients what they want to be told in this situation. And that was something we were interested in exploring a bit further. So I think at this point, we're going to try and get you involved again. So let's just go back. Imagine that you are that patient who's had a severe headache and you've had this normal CT scan. Do you think you'd rather be someone who the doctor just says, the CT head is normal, come back if it gets worse, but it's all very reassuring? Or would you rather the doctor acknowledges that very small risk that you may still have a bleed and sort of explains that's why it's important to come back? So if you want to vote now, I can't see how many people have voted yet, but at the moment, a strong preference for having greater uncertainty communication.
So only 2 people have voted.
Only 3. I mean, we're aware this is clearly not a very scientific method. We have primed you.
But we're about to add our scientific method in a second. But yeah, we're interested in knowing how many people and what you thought before we show you how it balances. But interesting to see that the things that you as a group said earlier about anxiety really was reflected in the reasons that doctors gave for doing it and not doing it. So her competence and the anxiety was really reflected. Okay, I'm going to give it another 30 seconds. Take it. But very interesting that with this small and I'm assuming pretty well educated group on this space, there is a clear preference for wanting to be explicit, for the honesty, for being explicit about the small risk of bleed on the brain and explaining that's why you should come back. Okay. But a reasonable minority that just says it's normal. Okay.
So you'll be glad to know that we didn't just rely on Slido polls for the rest of our research. We did try and explore this using a slightly more scientific methodology. So now I'm going to talk CODIS 2, which is essentially another vignette study we did, which this time was much more patient. So we were much more interested in trying to work out what patients want, what the effect of communicating uncertainty on patients might be. So in this study, the participants were all members of the general public, aged 18 years and over, living in the UK. As I said, we were really aimed in trying to understand patient preferences for this sort of communication, and also trying to understand what the impact of communicating or not communicating diagnostic uncertainty might be on patients. I think the next slide probably explains things instead of what we did slightly more clearly. So we produced 4 different video vignettes, which all depicted a doctor talking to screen. So when you were watching the videos, it was a bit like you having a sort of teleconsult with the doctor, where the doctor was talking to the screen, explaining what was going on. We chose to focus on 2 of the scenarios from CODIS 1, the headache scenario and the change of bowel habit scenario. And for each clinical condition, we produced 2 different videos. One which depicted high communication of diagnostic uncertainty, and one which depicted low communication of diagnostic uncertainty. So one which involved quite a lot of acknowledgement of the uncertainties around the diagnosis and the potential differential diagnoses, and one condition which didn't involve any acknowledgement of uncertainty. In terms of how people moved through the study, we recruited patients to the study and then randomized them to group 1 or group 2. So group 1 patients all watched the change in bowel habit scenario, and group 2 patients watched the headache scenarios. We then further randomized them within group to either watch the high uncertainty video first or the low uncertainty video first. After watching that video, we then got them to do an online questionnaire, which involved a few different questions about how they sort of felt about the communication they just watched. So we asked people things such as their overall satisfaction levels, the degree to which they trusted the doctor, how worried they were by the information they'd been given, how much they understood of the information they'd been given, and also how likely they'd be to return to the doctor if their symptoms got worse. Essentially, how likely they'd be to follow the safety messages. After they'd done that first questionnaire, we then showed them the other video they hadn't already watched. Once they'd watched that, they did the same questionnaire again. And then right at the end, after they'd responded to both vignettes, we essentially asked them which one they preferred and why. After they'd done that, we also collected some demographic information. And we also got everyone to fill out something called the IUS-12, which is a validated scale, sort of measuring people's intolerance to uncertainty, essentially getting a sense of their general disposition, their general thoughts about uncertainty on that. So overall, we found a preference for the higher communicated uncertainty videos. So people preferred, the majority of people preferred the video which involved higher communication of uncertainty. And that was the same for both the headache and for the change of bowel habit scenarios. This was in spite of the fact that people found the higher communicated uncertainty videos significantly more worrying. Now it's worth noting the effect size here was very small. So we measured worry on a 0 to 10 numerical rating scale. And essentially, the higher uncertainty video moved people about just over 1 point on a 1 to 10 scale, or 0 to 10 scale. So it was a fairly small effect size, but it was statistically significant. We didn't find any statistically significant differences for any of our other outcomes. So there was no difference in things like overall satisfaction or trust between the 2 different groups. What was nice about the study was not only did we ask people which video they preferred, but also why. And we got some really rich data and some really interesting responses from patients about why they preferred the video they did. Lots of people referred to the level of information or the detail provided. Those people essentially often said that they preferred the higher communication of uncertainty video because they liked to have extra detail. They liked to be told more about what was going on. It's worth noting this wasn't universal. So a minority of people reported they found the higher communication uncertainty video involved quite a lot of unnecessary or perhaps overwhelming information. But the majority preferred the greater level. Another really prominent theme that lots of people referred to was this idea of anxiety or sort of patient worry. And again, we had a range of views expressed. So although some people said they found the explicit acknowledgement of diagnostic uncertainty more worrying and a bit scary, we also had people who said they were more reassured and they were made less anxious by the sort of full and detailed description of what was going on. An example of this was in the change of bowel habit scenario. We had some people who said they were themselves worried about the possibility of bowel cancer. And if the doctor did not explicitly discuss the potential of a bowel cancer diagnosis, they would have worried about it themselves and they would perhaps have gone home and Googled it themselves. So for some people, sort of full and transparent acknowledgement of all the different things that could be going on was actually more reassuring. The next two quotations, on the next slide, we've got some quotations which I think really capture this interesting tension we identified, which was that for some people, even though a greater discussion about diagnostic uncertainty was worrying, those people still wanted to be told the information. So even though acknowledgement of diagnostic uncertainty might cause a small amount of anxiety, it was still better to know that information than not. Thinking a bit more widely about the sort of ethical issues raised by this data, we really highlighted two, I think, important ethical issues that we think need a bit more thought. The first one was this idea that we need to balance different ethical obligations in how much we disclose about diagnostic uncertainty. So clearly, there are some potential benefits for disclosing uncertainty. For example, in helping build trust with between the doctor and patient, perhaps giving patients increased agency, so giving them full information to help them decide, for example, whether to come back to hospital if their symptoms are getting worse. We have to contrast this with some of the potential harms of communicating uncertainty, one of which may be slightly increasing patient anxiety or worry. Although we also think it's really important to question the degree to which patient worry should be seen as a harm that has to be avoided. And perhaps actually we could think about it as a sort of necessary evil or inevitable consequence of giving people the information they need and value. What's also still a little bit unclear is the degree to which communicating diagnostic uncertainty might impact people's safety netting behavior. So essentially, does acknowledging diagnostic uncertainty make people more likely to come back if their symptoms get worse? We didn't particularly find evidence of this in our quantitative data, although in our qualitative data, some people did discuss that this might impact their thinking. The other question we're really interested in is how an individual doctor might judge what the patient in front of them wants to be told. So we found an overall preference for greater communication of diagnostic uncertainty. This preference was far from universal, and actually a significant minority of people said they preferred the lower communicated uncertainty vignettes. This is really challenging for doctors when we may be looking after patients who we perhaps haven't met before and don't have an existing relationship with. There's actually been quite a lot of research looking into whether demographic characteristics, for example, age or education level, can be used to predict what information patients want. But actually the results of all that research is pretty mixed. And there's not really firm conclusions about whether those kind of demographic factors can be used to predict informational preferences. We also think there are potential ethical issues with using demographic characteristics to judge what patients want, information patients want. For example, if we're using things such as perceived education level to decide what information a patient might need, we risk sort of perpetuating systemic inequalities and inherent biases. We also point out that lots of people say, well, can't we just ask patients what they want to be told? There are also some problems with this, because that assumes that patients know their own informational preferences and also are able to articulate. When we know that lots of patients do not always feel able to ask questions, and we know that certain patients from sort of minoritized groups are much less likely to ask questions in a doctor-patient relationship and often adopt a more passive role. So again, there's this risk that certain patient groups might be sort of biased against and might not be able to express all the things they want to. So why does all of this matter and what did we think? Well, based on the research we've done so far, we think that if we're in a situation where we don't quite know how much information a patient wants about diagnostic uncertainty, it may be reasonable to err on the side of slightly greater communication of uncertainty information. If we decide not to tell patients about diagnostic uncertainty because we're worried about sort of making them anxious or worrying them, we risk depriving patients of information that they might actually want. I think now I'm going to head back to, pass back to Zoe to talk through the final bit of the research we're going to talk through today, which is the ethnography study.
Thank you. So we came to the conclusion that, there's a lot of variety in what doctors are doing and that probably we should be telling patients more, but obviously vignette studies are limited because they are hypothetical. And so we also combine this kind of our controlled environment with looking at what doctors are actually doing and what patients actually understand is said. So we did an ethnography in 3 hospitals. We watched what was happening. This is colleagues Cat Cox and Janet Willers, Thea Hatfield and Janet Willers. We watched what doctors were doing. We watched their interactions with patients. We then interviewed the doctors and said, why did you say certain things? Why did you not say others? We interviewed the patients and asked what they had understood by what was said. And then critically, we interviewed them 2 weeks later to ask what they remembered was said and how they felt about it. And this allowed us a very rich data set, which allowed us to develop case studies and really directly compare doctors' intentions and patient experiences. And what we found, and this may seem like this is obvious, but it is important, what we found is we found certain practices that foster and impede shared understanding of the diagnostic process. We found practices that foster and impede patient agency, and we found practices that foster and impede patient confidence and trust in the system. But ultimately, that sharing information about the diagnostic thought process fosters shared trust and understanding. That's the bit that I thought you might think is obvious, but it was absolutely brought home every single time a doctor did fully explain what they were going on. The patient felt better about it then and 2 weeks later. In terms of us identifying the practices that impeded shared understanding of the diagnostic process, we found that there were some simple things that we think can be improved upon quite easily. So there was a mismatch between lay and medical terms, where, for example, a doctor might say to a patient, you've got some inflammation in the lining of your lungs, but then on a discharge summary, write pleurisy. And then the patient, when we phoned them 2 weeks later, said, the doctor didn't tell me I had pleurisy. So this idea of a mismatch of language means that there's this kind of lack of trust and lack of confidence. There's a mismatch in expectations of patients often wanting to go to A&E, wanting a diagnosis, and doctors actually just wanting to exclude the dangerous things and that not being explained enough. There was a clear problem when doctors didn't explain why investigations are being done. We had one patient who had a CT scan. She thought she had a migraine, but it was worse than usual. She came into ED. She had a CT scan, which was normal, and she went home having a migraine. And she said, why did they order a migraine? Why did they order a CT scan? Were they worried I had a brain tumor? No one ever explained it. And she was left actually with more anxiety. And then this idea of not completing the loop. So Kat and I both work in acute medicine, and we often, it's very busy, we often, if a test is normal, get someone else to go and tell the patient that that test was normal. And it turns out that that makes the discussion of diagnostic uncertainty much more difficult, because you've lost the trust that you had with the first doctor and you've lost the ability to ask for questions. So overall, not explaining the differential diagnosis and your kind of working or your sausage making in while doing investigations, while doing plans, impeded shared understanding of the diagnostic process and trust. So how might this affect practice? Well, we have some simple things that we suggest. We absolutely think there should be written communication at discharge, and you would all be astounded by how few patients get a written discharge letter from ED. You could suggest that we have AI translation of medical terms. So if it says pleurisy, then you write inflammation of the lining of the lungs. That might get rid of some of that language problem. We think we should encourage doctors to be transparent about the diagnostic process. And we think we now have a strong ethical and empirical argument for doing this, in terms of saying it's not a harm to cause anxiety. It may be patients are happy to have more information and balance that with a little bit of anxiety, so long as it means they've got more understanding. And we need to manage patient expectations about the fact that we're not always going to get a diagnosis. And we need to encourage doctors to complete the loop where possible, or if it's not going to be possible, to signpost when they won't be able to. So we think we have enough evidence from this really to be encouraging a change in practice, to say that we should be more transparent about uncertainty, we should show our workings more, and that we shouldn't be trying to just judge it on the patient. We should be restricting our variability. Otherwise, we risk bringing in inequities and unexpected biases. We're talking about doing work with medical schools, with the GMC, and general dissemination, and we have a dissemination day planned for September. But we hope we have enough time now to go to this immediate amount of dissemination, and we look forward to questions from all of you. So thank you very much. And I'm just trying to see if I can see what questions are coming in. Brilliant. Can I still be heard? Can someone talk in my ear? Excellent. So we have a question. I've noticed that my GP increasingly seems to ask, what do I think might be wrong and what do I want them to do? What is the appropriate balance between doctor and patient opinion? I think this is an excellent question, Peter. And there is this is what I was talking about saying, let me do the worrying for you. I think there is part of a doctor's job of actually saying, actually, I have 6 years of training and X years of experience, and part of my job is to say what I think is wrong and what I think should happen. And I think people expect that, and I think that there is room for that kind of guidance, not paternalistic behavior. I think that the question is, the reason your GP is asking these questions is because they're worried that there is a kind of hidden a hidden concern that you have or something that you've come to them for, and they want to make sure they understand it. Maybe an appropriate balance would be to say, this is what I'm currently doing, but in order for me to understand what would suit you best, I want to know if you've got anything you're particularly worried about or anything you particularly want, and then make sure that you're still putting forward your idea. Do you think being open about uncertainty will take more time? How can you justify this in a stretched NHS? So we do think it will take more time. Kat, in her vignette studies, the ones that were explicit about uncertainty took a little bit more time. But I think you can justify it in a stretched NHS because you can say, although it might take more time up front, ultimately it will empower the patients. We hope. We don't really have the evidence for this, but our belief is it will empower patients to come back when they do have problems. And we do have a little bit of evidence from our ethnography. We had a patient, for example, who had chest pain, it was an example of that loop not closing. Chest pain, someone else came and told her she hadn't had a heart attack, but they weren't explicit about what they were thinking about. And she represented because she was second guessing what was going on. She represented several times before someone could really explain what was going on and how much certainty could or couldn't be closed. So I think it's one of those things that you can be open about it. It will take more time, but in the long term, that will pay off. Someone, Julianne Morland, thank you, has written, this is a challenging topic. I'll just say, Kat, if you want to look ahead for the next couple of questions and pick up after this one. This is a challenging topic. Patients now have access to all of their reports online. If a CT report has diagnostic uncertainty and the patient reads this, should doctors, clinicians explore this with patients? Surely if uncertainty isn't addressed, patients will be worried that we haven't looked at results thoroughly and that we're withholding important information. So I actually agree. I think diagnostic uncertainty, radiological diagnostic uncertainty is probably a topic all unto itself. But I absolutely think we need to be honest with patients for exactly the reasons you say. We need to say, we have considered this and you're going to have a repeat scan in this time, or we have considered this and given your other risk factors, this is not worrying. Or this is an incidental finding, this is in line with the British Thoracic Guidelines or whatever. But if you don't tell a patient that you've even seen this, and then they have a repeat scan somewhere else and someone does tell them, they'll wonder if we at First Hospital missed it or we didn't tell them or whatever. So I think you have a responsibility to the patient, but you also have a responsibility to trust in the system. So that's where I'm at. Thank you. Kat, do you want to?
Yeah, so we probably have just one more quick question. So someone has asked, do you think there are times when you should always tell a patient about diagnostic uncertainty? So I think a lot of what our work has been doing has been looking at this question of, how doctors should talk about different levels of diagnostic uncertainty at different points in the diagnostic process. And I think that the conclusion we are erring towards is, generally, we probably should try and communicate uncertainty in lots of different situations. But certainly if we think there is a high degree of diagnostic uncertainty, particularly with regard to that question about safety netting, the importance of telling someone when we're not 100% certain, so they know to come back if their symptoms get worse, I think that's really important. So I would say, yes, I think there certainly are some situations when we definitely should tell about diagnostic uncertainty. I think that's probably about all we've got time for, unless Zoe wants to say something quickly in the next 10 seconds.
Well, I need to say that I was given an option of replying to these questions offline, and there are a few enough of them that I'm happy to do that if that is a possibility. So I'll work out if I can do that. So thank you very much, all of you.